who's going to take it over first, but we thank you for doing this. We always appreciate having you.
Wonderful. Thanks, Rick. I sincerely appreciate it. As always, we genuinely enjoy this conference. It's fun to get to showcase some of our, individual efforts that we've done here. We're lucky enough to be joined by two of our rockstar fellows. We have Ashley McConnell, who will be presenting our first couple of cases, and then Dan Cavazos, who is the fellow on rotation with me, and I beat him up pretty good today. So I'll hold back tonight on my commentary. Dr. Khalsa, I'll save that for you to pick on Dan, as rightfully so, as a fellow. Our topic tonight, we're going to engage in distal fixation for different types of constructs. The idea being that sometimes I hear the rationale that a patient is solidly fused from 4 to S1. We're going to extend their fusion from L1 to S1, and it's really adequate to stop with, S1 screws because they have a robust fusion at 5-1. And again, our conversation needs to revolve more around is pelvic fixation for fusion at 5-1. Does it serve to protect the pelvis from sacral fractures, all those kind of things. So hopefully we have a couple of good cases, variability in treatment, variability in options that can kind of highlight some of those. And obviously, as always, Rick, Jack, Izzy, we'll make sure, love to get your commentary and thoughts on some of these, because obviously you gentlemen are a wealth of knowledge. So Ashley, if you don't mind, if we can get things started with our first case, please go ahead and share your screen.
Absolutely. Is everybody able to see this?
Perfect.
Yes, that was great.
Okay, perfect. So I'm Ashley. Thank you so much for having us tonight. So the first case is a 67-year-old female who presented with progressive lower back pain and difficulty with upright posture, reports increasing symptoms with prolonged ambulation, which limits her ability to walk greater than 1 block, requiring her to stop and rest. She's tried both formal physical therapy and home therapies, and has tried epidural steroid injections, which have become less effective over time. On exam, she is neuro intact, 5 out of 5 strength in all tested muscle groups, 2+ reflexes. These are this is the APN lateral radiograph, which demonstrate her thoracolumbar degenerative scoliosis, kyphotic alignment, multi-level spondylotic changes. Of note, she does have an SVA of 13 centimeters and a PI-LL mismatch of about 23 degrees. Left sagittal and axial T2 weighted MRI cuts demonstrate multi-level spondylosis with central stenosis most severe at L3-4 with quite prominent epidural fat. And then these midline sagittal lumbar and thoracic CT cuts demonstrate pretty large anterior syndesmophytes in the lower thoracic region, as well as vacuum disc at L2-3 through L4-5 with quite impressive collapse. So assessment, 67-year-old female with severe spinal stenosis, neurogenic claudication, sagittal malalignment in the setting of thoracolumbar degenerative scoliosis.
Great, yeah. Thank you, Ashley. If you don't mind going back for a quick second, I'd like to get some of the thoughts. Rick, Izzy, or Jack, if you guys want to weigh in here. Obviously, 67-year-old, fairly disabled by this. This isn't, a subtle curve. Obviously, when we see a patient like this, the last thing we want to jump to is a very big operation, and having discussion over a prolonged period of time in relation to, what we may indicate her for. But just, off the top of your heads, when you see a curve like this, is there certain things that you're thinking, whether it's different types of fixation, different ways to approach this?
Well, David, I don't do scoliosis, but I'm going to defer to my partner Izzy. But I will say one thing: he is known to say your treatment should be patient specific. So I'll be interested to hear what he says.
Symptom specific, Rick.
Sorry.
Thank you for that introduction. Symptom specific surgery. So clearly, this lady's struggling, and these are now very commonplace. I was in the penalty box today, my clinic today, and I saw 4 of these in a row, and it's the exact same story. Surgery obviously carries with it substantial risk. The decision to have an operation must always be based on the risk versus the benefit. I may have missed it, but she was otherwise healthy, didn't have any other medical comorbidities, I presume. So
Correct.
we want to make sure that we've optimized her bone health. That's the first thing. And I know she's struggling, and I don't hesitate to delay surgery to give a chance for some improvement in her bone health, and then decide what I need to do. What are her symptoms? If this is an isolated radiculopathy, maybe it's just a single or two level decompression. If this is truly the sagittal malalignment with the stenosis and she really can't do what she needs to do, she's going to need a global reconstruction. And that's where we get to how we're going to do this, what we need to address the biomechanics with, what's the distal fixation going to be like, what's the proximal fixation going to be like. And I'll go on record right off the bat. Whatever decision I make, it's almost always the wrong decision. If I decide to go longer, I get infected. If I decide to go shorter, I get a PJK. If I decide to lock into the pelvis, I get a broken rod. If I don't lock into the pelvis, I get distal junctional issues. So it's just you just got to play the cards and go with it and explain to the patient as best you can. But in her, I'm looking with the story that I've got here and these films. I'm looking at a long construct in her, probably up to T4 or T5, and obviously pelvis up.
Dr. Lieberman, quick question regarding a long segment fusion here, since we're on the topic of distal fixation options. Does bone health, will it impact your decision making for distal fixation here? Now, obviously, I don't think anyone's going to say stop at S1, but may it change the amount of pelvic fixation you do, the type of pelvic fixation you do? What's kind of your thought process, and how does an osteopenic patient affect that versus a normal bone density patient?
In the spirit of disclosures, I'm a very liberal user of cement. And I'll, if I'm concerned about distal fixation, I will fill the iliac wings with cement. More recently, there are now much better commercially available distal fixation implants that have in-growth, on-growth features that help you out. But you still have to have the bone physiology. The patient still has to have the machinery to create bone and to fix those implants. So yeah, one screw, two screws, a transsacral bar, whatever it needs to be to get that solid foundation to hold the rest of the spine up. And most importantly for her is to get that pelvis back into a neutral position. I can't see the x-ray very well, but it looks like she's retroverted probably at least 20, 25 degrees. And the only way you're going to get her pelvis back into neutral is with good fixation. And that's probably going to be S1 alar iliac and S2 alar iliac screws, and potentially something else in S1 pedicles or into the iliac, the posterior superior iliac spines to really lock that pelvis and use it as a fulcrum point to get the rest of the spine back and the pelvis in neutral.
Everybody. Jens asked a question. He said, can the patient lay flat supine?
Yeah,
Ashley or David?
it's a great question, Dr. Chapman, and we're fortunate. So typically for these, I will look at the Scout CT scan, and she can lie flat. And again, the Scout CT scan helpful from my perspective because it kind of gives us a gauge on how flexible they are when they're non-weight bearing. So certainly something that I look at. Is, yeah, I think great point. Oftentimes we lose the forest through the trees, right? We can see this curve, and really they have a rip-roaring L5 radiculopathy from something, where they just need a little laminotomy for ammonotomy. So obviously patient specific is incredibly important. I think that this lady, kind of demonstrated more than that. I usually try and break it down into, as you said, looking at her coronally is the fractional curve on the left side at 5'1". The bulk of her complaint is more the concavity on the other side. so on and so forth. But this lady, unfortunately, she needed the full Monty, and I agree with you. For me, when I start thinking about longer constructs and her kind of thinking T4, I do start to supplement my pelvic fixation. I agree with your bone health is an absolute must. If not already an anabolic agent for 3 months, weight optimization, no smoking, hemoglobin A1C less than 7.5, all those kinds of things. But for me on these bigger construct, I agree with you. I like 4 points of fixation within the pelvis, really add and kind of making sure we bring her back and, leave her with a solid base.
So if I may just say, so for me, a forward bend position is always something that has a story behind it. And I don't want to just see it structurally. So rigid versus flexible is obviously something we're all indoctrinated in. But beyond that, the question for me is not just looking at a CT scan, but doing a supine physical exam and examining the hips for hip flexion contractures, knee for knee flexion contractures, looking at where the deformity is and where it corrects. Sorry, I'm still on the OR. And the other factor is that these patients are usually deconditioned. So this is a classic posture. There's an escape posture in stenosis patients. They bend forwards to give themselves a little reprieve. And that then gets an acquired habit as they get poor orthotic help, like walkers that are too low or a cane, even worse. And the other thing to look for, I like CTs on this, is to look for spondyloarthropathy. She has very large spondylophytes anteriorly. So this is probably going to boil down to deformity surgery, but I just wanted to make a pitch to add a routine recumbent exam for patients who have or present with forward bent postures, whether it's the neck or the lower back, and to explore them for depression and other factors. Yes, I'm a spine surgeon. Yes, I just did a deformity surgery, but yes, I do think we should have a little bit of more open, circumspect assessment. Thank you.
Perfect. Yeah, just as Jens commented, just because someone has a deformity doesn't mean they obviously need a deformity surgery. And it's important, last thing you want to do is correct this and someone has a hip flexion contracture. That's a big deal.
So what did you do, Dave?
Actually, are you okay moving forward?
Yes. So our surgical plan was initially for a staged operation, starting with a T4 to pelvis posterior fusion with a L3-4 lumbar laminectomy. That was going to be followed by an A-lift from L5 to S1, which was ultimately aborted given she had some postoperative hypotension after that first stage. So here we've got some films which demonstrate placement of the pedicle screws from T4 down to S1, 4 points of fixation at the pelvis, including 2 iliac bolts, 2 S1 AI screws. PCO was also performed from the T10 to L1 levels, and then primary rods were contoured, placed with significant reduction of her preoperative deformity. The accessory rods run from the S2 AI screws into connectors. And then, of course, the final step was the L3-4 laminectomy.
Hey, Dave, this looks like a beautiful construct. Really nice job. The timing of the staging for this, because I think staging is very reasonable for a long operation posteriorly here. What was the thought? Anterior first versus anterior second? Obviously, we have to work around the schedules of our access surgeons and things like that as well. What was kind of the game planning here?
Yeah, unfortunately, some degree of that got introduced into it. Obviously, I prefer a little more lordosis at 5'1". I honestly think she's a little bit undercorrected through the lumbar spine. You can see she's still retroverting her pelvis a bit to kind of get back there. These are films from 2 years out, so she's doing okay. But obviously, I'd prefer to see a little bit more of a natural curve through there. For me, it's typically anterior first, followed by this, and it's often rare that I tend to stage things, especially if we're just doing 5'1" or maybe 2 levels for more of a lordotic compensation. I think though it raises a good point. If you start getting into a little bit more prolonged surgery, a little bit more blood loss, especially with this, and you're doing a lot of bony work in the back, it adds to the time. But again, I think that, that probably would have helped us anteriorly. I'm not in love with the lumbar correction, but fortunately, I think overall she's doing really well just from a balancing perspective. And I think a lot of it was that driver, that thoracolumbar kyphosis, which we were able to straighten out.
Hey, Dave, what was her bone quality? Because I'm amazed that at 2 years out, she hasn't gotten a PJK and she's got a pretty good angle at the upper part. And obviously, maybe that's not the way she looked initially, but it's
Yeah,
amazing that she's still holding up.
I think again, fortunately, she good bone health. She had been on an anabolic agent for 6 months, and just a very, understanding, sweet lady. I think exactly, Yen's point is well taken. The most important thing I find for these patients post-operatively is upright posture with a horizontal gaze. I really hate walkers. I get them with walking sticks right off the bat. Really encourage to make sure, their elbows are at 90 degrees, kind of keeping that position. And she was super dialed in with physical therapy. So, kudos to her. And obviously we can see these fail pretty dramatically. And I think the credit goes to her in terms of why she's doing well.
So the one thing I think why she's doing so well is despite your self-criticism about not enough lordosis, if you look at that standing film, her ear is over top of her hip. She's sagittally balanced right now. So she's going to be able to tolerate this for a long time. So I don't know that you really undercorrected her. I think you've got her right in the zone that she needed to be.
Yeah, I had a question for we have our other partner, Dr. Andrew Zhang on, who had been in practice a couple of years and then went back and did the Lanky Fellowship last year. Andrew, in your practice, in your experience with Dr. Lanky, is this a 4 pelvic bolt, 4 rod across the lumbosacral junction every time? What's your workflow? What was your workflow last year?
Yeah, well, first of all, thanks to the Seattle Science Foundation, and thank you guys for inviting us. Really thrilled to have the opportunity to do this. So in doing a lot of cases with Dr. Lanky and seeing and exploring how he's evolved his practice over time, he's, gone from 2 rods to 3 rods to 4 rods. And, we've been able to study that pretty extensively. And we've been able to see how the different amount of rods will lead to different outcomes like rod fractures, like revision rates, pseudarthroses. And what we've seen and what we've published over at Columbia was that, the highest, as you can imagine, rates of success are usually seen with the 4 rod constructs, right? And so we are almost universally doing that now. We've seen that compared to 3 rods, the 4 rod construct has about 5 times greater success in terms of less rod fractures. But when you control for like revisions, it's unfortunately still about the same, but we can certainly see that our constructs are that much more durable when we control for like BMI, habitus, and the other nutritional factors as well. So we do 4 rods in mostly all our cases, 2 S2AI screws, 2 iliac bolts usually, and then we usually use those as kickstand rods to help with sagittal correction, but also we can also correct sagittal imbalances as well with those as well. So this looks pretty spot on.
Dave, what was your technique here for your pelvic fixation? And did the fact that you had 4 rods here make you feel more comfortable bailing on the interbody fixation?
Yeah, I think so. I think obviously, a nice 5-1 lift helps fusion at that segment, but with this, I felt pretty good about it. Yeah, for me, it's kind of freehand technique of the S2AIs. I usually do those first and then kind of put the bolts where they land and match up the rods appropriately. So for me, if I'm going above T10, I typically do use 4 points. Not good science, but T10 often I'm doing 3 potentially, and anything less usually 2. But thanks, guys. Thanks for the commentary on this. Ashley, do you mind advancing to the next case?
Of course. So this is our second case, a 70-year-old male, history of prior lumbar surgery back in August of 2025, who presented with persistent lower back pain and worsening left lower extremity radiculopathy. Described the pain in the L5 distribution, does have this history of surgery by an outside surgeon, which was an L3 to 5 TLIF with posterior spinal fusion. On exam, well-healed prior incision, sensation was intact, and patient reported 5 out of 5 or demonstrated 5 out of 5 strength in all muscle groups. Did have a positive left straight leg raise.
Hey, Ashley, just before you advance, even just looking at these X-rays off the bat, and I know sometimes we can get confused when we're looking at patients with coronal imbalances, scoliosis, is there a world where those L5 screws are potentially in a good place where they are right now?
I would be very worried about the current placement of the L5 screws. I know the surgeon used a cortical trajectory for his screws, but I would be very concerned that they're not necessarily contained within the pedicle. Again, AP and lateral radiographs demonstrate this L3 to 5 fusion construct. Of note, pretty significant mismatch, PI to LL of 35 degrees. These are some select sagittal and axial T2 weighted MRI cuts, which demonstrate this prior fusion construct, moderate central stenosis at L2-3, and then mild to moderate stenosis at L1-2. We also have some sagittal and axial cuts from the lumbar CT, which demonstrate loosening of the bilateral L5 screws with placement into the neuroforamen. Pseudoarthrosis is also seen at L4-5, and then there is a bilateral L5-S1 isthmic spondylolisthesis. So assessment would be a 70-year-old male coming in with migration of his pedicle screws into the L5 neuroforamen, pseudoarthrosis at L4-5, as well as sagittal malalignment in the setting of a prior L3 to 5 TLIF.
So I guess before we get to the what actually happened here, Dr. Lieberman, you want to maybe give us your thoughts here about plan of attack, problem-based treatment here?
Absolutely want to give my thoughts. Wrong surgeon, wrong operation, wrong reasons, poorly done. I was interested, Ashley, you used the term L5 screw migrated. I don't think it migrated. It was put there. It's just technically wrong for multiple reasons. And then to think you've got these little TLIF cages that are going to do anything at that in those interbody spaces with the structural abnormality you've got at the lumbosacral junction. It's just bad thinking. It's just bad thinking. So this is one case where, and again, I see a lot of these. And my first concern when I say, because this is less than a year out from when he had his surgery, right? What was it?
Correct. Yep. August of 2025 was his
Right.
index procedure.
So my first concern is always infection. And now we've been auditing my cases on the revisions, and we're well over 40% of the cases have some form of occult infection. So I would target this by first removing all the hardware, debriding everything I possibly can, taking cultures, and seeing what he's like. What we've found is that a third of the patients in this situation, when I remove their hardware, they come back and they say, I'm good, I'm better, I'm fine, I don't need anything else done. And if that's the case, brilliant, we leave them be. The rest of them, on the other hand, need something else done. And once you've determined whether there is an occult infection or not, and you can get better imaging, you can figure out the strategy to reconstruct this. And looking at this, for me, this would be a front back case, but I probably would 3 to 6 months later, if it was an infection, or 3 to 6 weeks later, if the cultures came back negative, start with a posterior reconstruction with very generous Smith-Peterson osteotomies, facetectomies to realign him appropriately, and then bring him back for an anterior procedure. Now, I can see his vessels a little bit on the scan. It looks like he's got a little bit of calcification, so I may have to withdraw that anterior recommendation if we get the full studies. But then using my anterior approach to just fill in the gaps that I've created with the posterior instrumentation. And clearly locking him into the pelvis. So again, you've got a foundation to get your correction from. So those are my thoughts on it. But it starts with just bad surgery to begin with.
So,
And can I ask a question? You know, I look at this and I've learned from Izzy and other partners that do deformity, and even us doing disc replacement in the lumbar spine, I'm coming to the point that, and we are fortunate that we have an EOS, that we should do that on every patient that we operate on. Any thoughts?
Absolutely. Full length x-rays, head to toe. You want to see what the hips are doing, what the knees are doing, what the ankles are doing. And oh, by the way, we're operating on the spine. So let's match it all up properly.
Completely agree. We're actually we have one unit within our health system right now. We're trying to acquire a second right now to be at several of our sites. I think anterior approach was mentioned here. That sacral slope, you maybe go back a slide or two, Ashley. Go back again. So it's really high sacral slope here. You guys feel confident getting in there with like angled instrumentation?
So the pubic symphysis looks like it may be in the way, but this is why I'd go from behind initially and see what the gap is, how much I can pivot that L5S1, if at all. If it doesn't pivot, then I'll just ignore it and maybe even do something to get a foundation. There's a reverse Bowman from in front, put something down from L5 into the sacrum to gain that stability that you need there. So you're biomechanically more sound.
Dr. Chapman.
Yeah, I agree and disagree with Dr. Leo. I more agree than disagree. So this to me looks like a really badly done decision-making process. This patient had an isthmic spondy, and I'm not sure why 3 to 5 was fused above that. But that's just a missed surgery. I don't know what. The robot directed them in the wrong direction. Probably was the robot's fault. Can you go back to the lateral MRI? So this is, for me, one of the shortcomings of the current dogma of alignment. This patient has a corniform, meaning a hook-shaped sacrum, okay? If you start looking at sacral anatomy, the people have a very straight and flat sacrum, and there are people who have a very crooked sacrum. If you look at that ventral sacral surface between S1-2 and S3-4, he has like an almost 90 degree, I'll say 85-degree angle there. So this is why he has a steep pelvis. So this is something that you, by the way, see in collagen disorders and osteoporosis and things like that. But this, for me, together with that brutal atherosclerosis, and moreover, the substantial looking sarcopenia that this patient has with, this is not even Wagyu quality anymore. This is really some muscle strands and fat. I would just do this from posterior. I would keep it simple. I'd take the hardware out. I'd give him the relief that he needed in the first place by fusing my L3 to the pelvis. I would do a posterior osteotomy, an intradiscal osteotomy, reduce him, seat L5, and that's the key thing about this, on top of the sacrum again, so you have to resect the posterior inferior osteophytes of L5 and superior osteophytes of S1, and then realign him from the back. I would do this all from the back. I would not try to go in the front and go through his calcium reinforced reinforcement spines. But the key points are, I think this is a wrong surgery. I always like to, in these contentious cases, get the original films, because over, short, or long this may come up. And I would do single stage posterior realignment, throw the old garbage screws out, and do proper pedicle screws L3 to pelvis with an osteotomy L5S1, and do bilateral expandable cages on the back. You can do a perfect realignment. Those are my 5 thoughts. Thank you.
Let me ask you this, because I agree with you, and obviously you'll see what we did here. The current condition of the L5 pedicles really worried me, given both the potential for previous pedicle screw placement not that long ago, the isthmic defects, the migration, that kind of going into this, I wasn't sure I was going to feel confident putting screws in L5 to kind of put the ice cream back on the cone at 5-1 here. But I think we can all agree that 5-1 is probably the biggest driver for any sagittal malalignment that's going on here. And obviously, this is a guy who's complaining of radiculopathy from a screw in his nerve root. But obviously, we want to leave him in the best possible alignment when it's all said and done.
I would need a CT scan, and I would not worry about the L5 pedicles too much. Take the hardware out, do my posterior laminectomy, osteotomy, do the pelvic instrumentation, do the S1 screws, start them low, so like Jackson screws, starting them low, aiming up. And if under direct vision, you'll see the pedicles. If there's a chance to realign and under direct vision, fire bicortical pelvic screws, great. If not, then you have, thankfully, through whatever reasons that previous surgeon decided to do L3, 4, you have 2 sets of screws that will help you with an alignment. You can do a standard reduction maneuver from the pelvis up.
Sure, Ashley, why don't you go on with what we did?
Absolutely. So our surgical plan was a revision L1 to the pelvis, posterior spinal fusion. Game plan was to remove the posterior instrumentation, then re-instrument L1 to S1, use a modified Bowman technique at L5S1 to achieve inner body screw placement, bilateral SI fusion, followed by multi-level posterior column osteotomies. So again, the prior instrumentation was removed. In the bottom image, you can see the modified Bowman technique, where a posterior S1 starting point was utilized to place a self-harvesting bone implant spanning the L5 to S1 disc space. Additionally, bilateral SI fusion devices and pelvic instrumentation were placed under navigation, followed by pedicle screws from L1 to 4. ECOs were performed at each level, followed by contouring the rod. Some additional images just demonstrating placement of the primary rod. And then here are the final postoperative images, including that supplemental rod connecting the pelvic screws to the more proximal construct.
Yeah, and so to Dr. Lieberman's point earlier, I think some of this new technology with some of these self-harvesting bony ingrowth, bony on-growth screws, that give us the option for SI fusion concurrently with a S2 alar screw, are I think are pretty nice. And then we made a decision to basically fire screws starting at S1, kind of capture the rest of the L5 body there, just because we didn't feel like the L5 pedicle was really safe to instrument. And obviously this poor guy couldn't tolerate, another, nerve issue here. So I was pretty happy how the construct shook out here. We ended up going up to L1, which I know is a little controversial, but just to get past that 1-2 disc there and the more significant spondylosis. I think a shorter segment fusion also reasonable. Obviously, we wanted to stop short of going up higher in the thoracolumbar junction if we can avoid it here, because otherwise he's pretty active, despite a little bit of sarcopenia. Pretty active guy. So, we actually published recently a meta-analysis kind of looking at these like bedrock technique, concurrent SI fusion, with S2 ALR fixation. And I think a lot, there's no great literature on it right now, but at least the literature is out there, kind of alludes that there's probably some value to potentially doing a concurrent SI fusion. And I think especially when that SI fusion can happen in the same instrumentation product that also gets your distal fixation, I think it's kind of a no-brainer for some of these cases. So this is one of my first jaunts with this type of product here, and I was pretty happy with it. But I'll open it up to the panel. Anyone else have any experience with some of these combination SI screws that also have tulip heads that allow for kind of some dual fixation?
So yeah, I do have a lot of experience with them, and in the spirit of disclosure, my name's on the patent for those screws, and um, it is a device that we had a great design team. We had multiple surgeons putting together all the problems that we've had, and that's what we came up with collectively as a group. And the granite screws, they work really, really well. They're very solid fixation, but it's still a screw, and you still have to adhere to the biomechanics. You still have to line it up properly. You still have to get the tulips in the right position so the set screws are in. So it's nothing is really easy. You have to pay attention to detail with all of these things. But this is a very good option to create your pelvic fixation and create your foundation to build up from.
Do you have any follow-up on this patient? How far out is the surgery?
He's not that far out. I think he's less than like 2 months or so. So 2-3 months. He's doing okay, but obviously he's been through a lot here. Obviously we'll get some full length standings on him as well. I know we didn't necessarily do major sagittal modifications here other than just kind of optimizing the current T lifts that he has there, but we did not make the decision to go back into the disc spaces and pull those things out. I don't know, Dr. Ziegler, would you do anything different here, or what are your kind of thoughts?
I think you're kind of stuck. I mean, the front door was not open. Oh, am I muted?
Yeah. Yeah. So, otherwise I'll very routinely go in the front, take old T-lift cages out. I mean, it's just a fantastic option for, a T-lift suit arthrosis, but I didn't feel like it was a great one here. And just trying to get that 5-1 stabilized here was my concern, especially without the ability to get 5 fixation. So that's why we went with the modified Bowman technique here, which, to Dr. Lieberman's point, yeah, I mean, you still, just because you have this new tech, you still got to, follow the rules and stay within the guidelines. But hopefully this guy holds up.
I'm sure he's happy he just doesn't have a screw in his nerve root anymore.
Yeah, goes a long way.
Yeah. Dan, do you mind sharing your screen now, and we'll keep it moving with our last 2 cases?
Yeah, absolutely. Does everyone see this okay?
Yeah, we do.
Yeah.
Yes, Dan.
Great. Here's the first case. It's a 62-year-old male, no history of prior lumbar surgery, presenting with significant low back pain and bilateral lower extremity radiculopathy. Had failed multiple conservative treatments. The back pain rated down into the bilateral buttocks mostly. He's also been having some chronic right ankle dorsiflexion weakness. He's having impaired walking ability, and his pain is worse with activity and improves with rest. Here are more focused lumbar films, and then also his exam showing 5 out of 5 strength in the lower extremities, aside from that right ankle, which is a 4 out of 5, an intact sensation. Looking at these lumbar films in a little bit more detail, we see That right-sided kind of acute curvature there, most pronounced from L2 to 4, and also his sagittal imbalance with a relatively flat back with a lumbar lordosis of about 23 degrees, pelvic incidence of 43, and a mismatch of about 20 degrees. The SVA was only about a little bit under 5 centimeters total. In terms of the MRI, these are multiple axial cuts going down. Nothing really at 1, 2, pretty mild at 2, 3, maybe moderate at the 3, 4, mild at 4, 5. Nothing really at 5, 1. And then you can see some varying degrees of foraminal stenosis on the left side and right sided sagittal cuts there with some pinching of the nerve roots. So overall, it's a 62-year-old bilateral radiculopathy, sagittal and coronal malalignment with a right foot drop. I guess I'll take a moment and see if anyone has any input on this case.
Dan, can you go back to that MRI scan and show us the axial cuts through 4, 5, and 5, 1 again?
Yep. There's 4, 5 in the bottom right.
Okay.
5, 1 is the top left there.
Yeah.
Well, I'll tell you these, similar to Izzy, what you said before, the classic degenerative scoliosis. I look at first their fractional curve. Is that the bulk of their symptoms? Is it the concavity of their curve? Meaning, can we do something segmental, or is it, the entirety of the curve? And then kind of base my treatment on that, and then kind of tailor the intervention I'm going to do accordingly, trying to do kind of more of a minimally disruptive surgery to the best that we can.
Yeah, so this is an individual, and when I look at a spine like this and see that X-ray, one of the questions that comes to my mind is this spine stable? I mean, is this going to progress further? And the likelihood of this progressing further is or substantially progressing further is very, very low. So if he's coming in predominantly with a radiculopathy and a foot drop, I'm probably doing a focal decompression on him first and see what he's like. Do the decompressions, make sure you do really good subarticular decompressions, lateral recess decompressions, foraminal decompressions, get that L5 nerve root traced out as best you can, because I don't think his spine's going to fall apart. And if it does fall apart, then you just bring him back. But at least you've already done the decompression and potentially helped him with his radiculopathy.
I agree. I think exceedingly reasonable, right? I think a lot depends on the conversations you have with someone as they sit there, what's truly the bulk of their complaint. I agree with you. For me, sometimes that foraminal decompression in an asymmetrically collapsed disc space is pretty difficult. I find that, oftentimes I'm removing the facet joint on that side in its entirety to decompress it. But again, I think totally in agreement. Worst case scenario, you do something like that, you're pretty much exactly where you are now, so you haven't burnt any bridges. So I think certainly very reasonable. Dr. Zhang, any thoughts?
I think that we have to kind of heed to what Dr. Lieberman said, treat the symptoms and not necessarily treat the curves. And, we really have to just see what his main goals of the surgery are, right? I think that certainly he's got this fractional curve with a lumbar compensatory curve as well that can be contributory to his symptoms. I think it's certainly reasonable to start with a decompression like Dr. Lieberman had stated, but you do have this asymmetric 4 or 5 level. You certainly, if you need to revise it, want to try to horizontalize it, and then we can talk, about perhaps the rest of the coronal malalignment, the sagittal malalignment, if that's the case. But I think a simple decompression is reasonable, but certainly I would have a low threshold for correcting them more as well.
And I'll chime in with devil's advocate here, because I think everything it said is totally on point. A concern I may have is this patient's coming with a foot drop with the 2-level, pretty severe neuroforaminal stenosis. And again, some of the challenges with a lumbar foraminotomy, from the inside out, are you ever really going to be confident that you fully decompress that nerve to tell that guy or gal that, hey, we're going to hope for the best here. Fingers crossed. Let's hope this nerve gets better. Let's hope your foot drop improves, depending on the acuity of it. And obviously there is some comfort to doing that more extensive decompression with the complete facetectomy there, especially with some of that, that little fractional curve concavity there on that right side. So all reasonable options. But I would have some concerns about, if it's quote unquote just pain. Great, we're going to know if we did it correctly or not. But with the weakness, I would have some concerns.
Very fair. And I'll let you know that in addition to the right side symptoms, he's having severe left L3 and L4 nerve root issues as well from the concavity of his curve. So again, not isolated right lower extremity issues.
So again, looking at this, it's the stability issue, and looking at these X-rays, and this is impression only, but even if I do very substantial foraminal decompressions, I don't think his spine's going to slide off. He's not going to listhese. He's not going to fall apart. The discs are collapsed down. He's got good, well, not good, but peripheral osteophytes that are kind of bolstering things in place. So I wouldn't be at all concerned about doing the decompression first and then seeing what happens. And if we have to come back, we come back and explain that to him.
Yeah, it's fair.
And how about adding an interbody fusion while you're doing it, either a TLIF if you're already doing a facetectomy, Dave, or even a 2-level 360 to horizontalize him a little bit, help the vertical component of his foraminal stenosis, and make you feel a little bit better about being more generous in your posterior decompression as a possible first stage. Yeah.
And for these asymmetric collapses, I'm a big proponent of, evening out the disc space and allowing for indirect decompression in those segments. And again, this is not an isolated right lower extremity radiculopathy patient. This is a, bilateral radiculopathy, neurogenic claudication, kind of, stoop forward. But I agree. I feel better about straightening out the asymmetric collapses in regards to kind of helping realign things as well. But he makes a great point. He is pretty rigid here.
And Dave, suppose they just had a specific L5 on the right side, and any consideration, as Jack said, just doing an A-lift, just trying to see if you can do an indirect decompression and leave the rest of the curve alone.
I love that, Rick, for the fractional curve asymmetric collapse on the right side in this, where they have severe L5 radiculopathy from that exiting nerve root. I think it's a great operation, right? You elevate that disc space, standalone ALIF. I think those patients do really well. And similarly, God forbid they have progressive left-sided symptoms from the concavity of the curve later on. You've already set them up for success with a good 5-1 fusion. So I really love that as an option.
I can hear Dr. Arlay's voice in my head right now saying, "You're not burning bridges with an ALIF." I'm butchering a French accent, but I totally agree.
Dan, do you mind going forward?
Yep. So we did a staged L3 to S1 ALIF, and then a L2-3 direct lateral interbody fusion, and a percutaneous posterior spinal fusion. So these are just some fluoro shots of the ALIF starting at 5-1, and then moving up proximally to 4-5. You can see the 3-4 there at the top, and then a left-sided lateral interbody fusion at the 2-3 segment, followed by flipping them and doing a Wiltse posterior spinal fusion, leaving out those S1 pedicle screws as we have a ALIF interbody in the front.
Just curious here. So I find in my longer percutaneous constructs that it's a bit easier to seat the rod if, one, I leave the S1 screws out, and I intentionally try to put my screws in a position where it doesn't look like I'm maximizing lordosis, meaning I'm leaving the L5 screws a little bit more proud. Because I find passing the rod in situations where we have kind of more of an extreme lordosis, sometimes it's hard to seat those end caps percutaneously. So I've fallen in favor of leaving out the S1 screws, doing S2 AIs, and then leaving the L5 screws just slightly more proud than I otherwise would with an open construct.
David looked like he had a very, very big belly. And was he hard from the front?
It's a good question, Rick. You know, we do have, when it comes to these longer constructs, you're going to get a big incision, a lot of clips, and all of that kind of stuff, but you're going to get a great exposure. So we're very, very lucky when it comes to something like that. Not an issue whatsoever.
And there weren't that many clips, honestly, as
Yeah,
on the X-ray.
But I'll tell you, you know, typically we go into this with the understanding, you know, he likes to start at the bottom up. You know, we'll see where we can get to, and if God forbid we can't get to 3-4 or anything like that, then obviously we can do it from the lateral position. But you know, no real issue getting up there.
Hey, Dave, you know, I agree with you. I think if I'm doing perk S2 ALR screws, you know, for these kind of multi-level constructs, I think you end up really doing kind of perk S1 ALR screws, you know, and then trying to squeeze in an S1 pedicle screw is both technically challenging just to fit it. God forbid if you do it after you put your pelvic fixation, and then yeah, the you know, the proprietary intraoperative rod bending technology will really struggle with any acute angles or changes of direction that are so close together. So I'll usually leave my S1s out as well. You know, I think with a good A lift in the front, you know, I think it's usually a home run.
And how far out is he now, Dave? I'm sure he's doing great.
Yeah, Dan, do you happen to know?
Probably just a few months, right?
Good question. Yeah, honestly, I find these are pretty quick recoveries too. I usually say in comparison to my tendon pelvises, they're one appointment, you know, further ahead. So someone that I see at 6 weeks from a tendon pelvis, you know, that's what we see with these people at 2 weeks. Similarly, you know, where they're at 3 months is probably where a tendon pelvis is at 6 months. So they bounce back pretty quickly. I don't have any restrictions on them at 6 weeks. He can kind of do whatever makes him happy. And I think overall, again, you know, I agree with it. He's, you know, he was pretty locked in rigidity standpoint. I think it was more of a global issue than just a right-sided radiculopathy. But I really try and look for those because, again, if you can do something like a facetectomy or even an aggressive foraminotomy or even a standalone A-lift, that's, you know, the patient singing your praises right off the bat as opposed to putting them through a more prolonged recovery.
Hey, Dave, question for you. You know, who's in your mind the ideal candidate for like a minimally invasive kind of 360 construct here versus like a open posterior like you showed in one of your prior cases?
Yeah, I think if I can, if I feel like I can limit their pathology to L2 and below, and I think that again, you know, we can do facetectomies, full facetectomies through Wiltse or some of these specialized retractors, but I really don't think it's as robust or as beneficial as we think as when we're doing it open. So if I can kind of limit the posterior bony work to maybe a little bit of a facetectomy, kind of L2, maybe sometimes, you know, a little bit higher, but that person that has more of the traditional degenerative curve, bilateral radicular symptoms, right, from the concavity and the fractional curve, and someone that I feel comfortable doing indirect decompression on, I think is adequate, which again, someone that has more of a fairly dense foot drop, you might think that that's a bit aggressive, but again, you know, here we did an A-lift, corrected that asymmetric collapse, and then did a full facetectomy on that side through kind of one of those retractor-based systems that allows us to take it down.
Dr. Lieberman, just in the interest of discussion around distal fixation, in your vast experience with S2ALR fixation, I know what the literature says, but like the literature is again only okay here. You know, like how many of these do you end up taking out for screw pain down the line, or instead of taking out screw, are you doing a subsequent SI fusion, leaving screws in place? What's kind of your workflow with S2 ALR fixation?
So it all depends on the implant. And I enjoyed telling this story. You guys may or may not recognize the name Ralph Rashbaum. I know Rick and Jack know Ralph very, very well, one of the senior partners, founders at TBI. When I first got to TBI and I was doing SI joint fixation or sacroiliac fixation, and I was using one screw, he'd look at my x-rays and he'd sneak up on me in clinic and sort of hit me in the back of the head and said, "You're an orthopedic surgeon. How do you think that the joint's going to fuse with one screw across it? You need 2 points of fixation." And that's really what sort of prompted me to rethink the pelvic fixation and then relook at the biomechanics of the 2 points of fixation in terms of the sagittal forces, the coronal forces on it, and the axial forces along the extent of the screw. So when I was doing 1 point of fixation, I was taking out a lot of them at 2 years and 3 years because they came back complaining of pain. And it was a very typical pain complaint. They point right to the front of their hip joints and they say, "Doc, it hurts here and here, right in front of their hip joints." And I do the CT scan, and sure enough, there's haloing around those single screws. So that's how I kind of migrated to 2 points of fixation on each side, and then evolved into what we're now using with the bone ingrowth, on-growth devices that are available to supplement the fixation and give you a fixation and fusion across that joint. We are now in the process of looking at all the granite cases that have been done, and I don't remember the exact number, but the revision rate is like less than 0.001%. There's very, very few of them that have had to come out over the 5 or 6 years that we have been doing this now. So I think we've seen a change in the understanding of the fixation and a dramatic change in the clinical outcome of the fixation.
Yeah, I think that's a great point, and that's really great feedback. I always question myself, like, well, all right, if the one screw gets loose, that's an outpatient procedure to kind of pop it out. But obviously, one less outpatient procedure even for the patient is obviously a benefit. So I do think the future is moving in that direction for sure.
Yeah,
All
these were
right.
great. These were great cases. You guys have another case? We got about 2 minutes. That's the only thing. Or do you want to?
I
I
think
think that's great.
Yeah, I think
you know,
probably
I
in the
think
interest of time, we'll probably wrap it up.
Yeah, I was going to tell you, I mean, there's great cases and it stimulated a lot of great discussion. And I just wanted to compliment, the guys at Penn have been really good contributors to this series. But I was just thinking about it. We're just finishing our 6th year of these interesting case series, about to start our 7th. And for the younger people online, this all came out of lockdown during COVID. And that was the kind of partnership between TBI and Seattle Science, because we realized our fellows are home. They're coming in for emergencies, but there's no conferences and no journal club or anything, and we're not giving them an education. So we sort of leaned on the infrastructure at SSF as well as the content that both groups could contribute, and then started inviting our friends in. And so this series has really flourished, and you guys have really been really good partners in this as well. So I want to thank you for your participation and friendship over the years, because I think it's been a really good series. We've all learned a lot over all that time in all the different flavors of spine surgery. So we appreciate it. But Izzy, we're glad you were there to hold up our end of the fort. Rick and I were
The privilege is
a little out of
mine.
our element.
The discussion was tremendous, and that's the beauty of this. The discussion creates connections to do better work, better care, better thinking for our patients, and that's what this is about. So thank you guys, great contributions.
Agreed.
Yes, thanks again.
Thanks, everyone.
We'll see you next
All
time.
right. Have a happy and healthy new year, everybody. Welcome to 2026.